are going to cover the lung exam. All right? One of the more important exams. Usually in practice, we perform a heart and lung exam together. We're obviously going to break them. We're going to break them down individually because each exam has its own, components. So we really want everybody to become a master in the lung exam and then become a master in the heart exam, which we'll cover next week. And then 5th semester, we're actually going to teach you how to piece them all together. So you will see some overlap between this week and next week. But obviously for testing purposes, if we tell you to do a lung exam, we're just going to expect you to do a lung exam. If you do a heart exam, we'll expect you just to do a heart exam. All right. So there is 2 parts to the lung exam. We do a posterior lung exam, and then we go through the same motions for the anterior side. So what we'll do first is the posterior. Like all the exams we have done before, what is the first component of a physical exam? Inspection. Okay, so you can see up here on the big screen. All right, so vital signs, obviously, we would have already hopefully have done. The most important one relevant to a lung exam is respirations. Now, you can see here that there's 3 other components that we want to assess when we're doing not only respiratory rate, but we also include rhythm and depth. Does anybody know what we mean by rhythm? What do I mean by respiratory rhythm?
So it's smooth, it's not like...
Right. Is it even, right? Is somebody just normal breathing? Or are they... That would be an abnormal rhythm. What about depth? What's the easiest way to assess depth?
Chest expansion test?
So that's actually a quantifiable way to do it. That is really good. But basically, do we see equal kind of rise and fall of the chest? So remember, one of the things we taught you when you were assessing respirations, not only do you assess the rate, but you can also see. I can look at his chest. Do I see it kind of rising nice and evenly? Do I see, is the depth look normal from side to side? Is it timed, meaning, is the rate normal? So those are some of the things now you really want to start looking into. There are things like paradoxal breathing, hyperventilation, hypoventilation, that you can really kind of get a sense just by observing somebody. So really check respiratory rate depth. Now, use of accessory muscles. All right, they're up there, so I'm not going to obviously ask. But SCM and scalenes are the big ones. All right, what may cause somebody to have accessory muscle usage besides the obvious trouble breathing? What could cause it?
Smoking.
So if somebody has emphysema, right, and they're smoking, obviously they already have restriction because the compliance in the lungs. Does anybody know what I mean by that term, compliance? Lung tissue is supposed to be what? Elastic. It's supposed to have a specific compliance. As you inhale, the lung tissue is supposed to expand, allowing oxygen to basically come in. Well, as you smoke, that compliance decreases. Lung tissue gets damaged. It gets scarred. So the lung isn't as elastic. So air actually gets trapped because what happens when you stretch a rubber band? It comes back to its normal shape. Well, it's the same thing, right? Air wants to get in, and then we have to have CO2 out. Well, the problem is, when you have lungs that have bad compliance, air really doesn't get pushed out all the way, so you have air trapping. Emphysema is an air trapping disease. You guys are taking physiology now?
Yeah.
Have you gotten to respiratory physiology yet?
Yep.
So, what's that? Okay. So you'll learn definitely about that. You'll certainly learn more about it in pathology. But basically, patients with emphysema can certainly have accessory muscle uses because they're trying to get more air out. What else?
Diaphragm innervation.
What's that?
Like the diaphragm not being innervated.
Oh, then you're dead. But while you're on the topic, what nerve innervates the diaphragm?
Phrenic.
Phrenic nerve. What spinal levels make up the phrenic nerve? Jesse.
3, 4, 5.
3, 4, 5 keeps you alive. Right? So that's a really important one. Now, not to kind of get too off topic, but what's unique about the diaphragm? It's technically a skeletal muscle, correct? Well, what component of skeletal muscle is kind of true, but also not kind of true when it comes to the diaphragm?
It also has involuntary components.
Exactly, it has an involuntary component. All skeletal muscles are voluntary control, correct? Except the diaphragm. It does have a subconscious involuntary component. How? Well, you wake up, don't you? You sleep, right? So obviously when you're sleeping, you're technically not conscious. So skeletal muscles really aren't being innervated, but the diaphragm does have a involuntary component. I'm not going to get into the neurology behind that at this course. All right, exercising. If somebody obviously just runs a marathon, any basically people with pneumonia or other type of infection. If you see somebody in the absence of exercising, listen, if you're on like the sideline and somebody comes over after running a marathon or they're in a soccer game and they're seeing accessory muscle use, I'm not really concerned. I would expect that. What I'm really more concerned is what happens if you see accessory muscle usage from a 60-year-old patient that has just gotten up from your waiting room and now just onto your exam table. That's a problem. That means that there's obviously poor circulation, there's poor respiration, that's forcing this person to use accessory muscles. Why does somebody use accessory muscles? What happens? What's the whole purpose of it? Where do all these muscles have connections to? The ribs, right? So they're trying to get that little extra rib expansion to allow basically the lungs to expand more, to allow more oxygen in, okay? So definitely, like I said, accessory muscles are really, really, really good, and they should be assessed every time. And if you see them in the absence of somebody doing hard physical activity, you really got to investigate further. Okay, so we got that. Let me scroll down a little bit. Okay. Obviously, while you're here, you're going to see if you see any structural abnormalities. See if you see any visible scoliosis. Hopefully, you guys are learning about some orthopedic maneuvers that you can test for scoliosis. You guys gotten to those yet in the thoracic spine? All right, so we'll kind of revisit some of those in a little bit. All right, so that's really it. Obviously, you can certainly do your dazed, right? Do check for your discolorations, scarring, abrasions, everything that we've taught you so far. So basically, I see that he has a normal rhythm. He has got a normal rate. His depth looks fine. I don't see any bruises. I don't see any abrasions. I don't see any structural deformities, such as a scoliosis. I don't see any accessory muscle usage. So I'm pretty happy with my inspection at this point. Any questions on inspection? Easy enough, right? All right, the next component is palpation. There's two parts to palpation. All right, you see chest excursion and something called tactile fremitus. Let me go over excursion first. What we're trying to measure with chest excursion is, does the rib cage expand on both sides evenly? Obviously, when the rib cage expands, we're essentially, assessing, are the lungs inflating evenly? Okay? So, what we do is we measure in 3 spots. We go at the top, usually in the middle, and then I go kind of roughly around T7. All right, the bottom part. So, really simple how to do it. All right. Here's the spine. I want to go 2 inches lateral, and I want to get a good tissue pull. So I'm going to go 2 inches lateral, use my thumb, and then I'm going to apply a medial to lateral force this way. Here's the spine, medial to lateral force this way. Okay? Just going to rest my hands kind of, on the side here. All right, Alex, take a deep breath in. Exhale. And if you guys look closely, you see my thumbs moving. Inhale again. Exhale. You're seeing them separate, okay? They should separate evenly from side to side, all right? Don't worry about breathing. I'll just show you where the 3rd spot is, or I should say the 2nd spot is in the mid. And then I go low. Now, as you move a little bit lower in the thoracic spine, you're probably going to have to move a little further out, depending on how much muscle tissue there is, because really the whole purpose is, I don't want to be on the spinous process, right? The whole purpose is to be just paraspinal, because if I'm on the spinous process, I may get a false reading, all right? So here he's got a little bit more muscle tissue, so I'll probably start a little bit more lateral, and then I'll make my medial to lateral force. Go ahead, take a deep breath in. And exhale. All right, does anybody have any questions how to do that? Yeah?
Yeah, did you say the tissue pull is medial to lateral or lateral
Lateral to medial, my apologies. Yes, thank you. Yes, lateral to medial. Sorry about that. Okay? What happens if we see excursion in one but not the other? What's the big condition that we're really concerned with?
Ankylosis spondylosis.
So ankylosing spondylitis, that's usually going to affect it bilaterally, and there are specific tests where we can measure, chest expansion test being one of them, but I like where your head's at. But what about unilateral? We see a nice expansion on one side, but we got nothing on the other. Pneumothorax, yeah. All right, where the lung is actually collapsed. If the lung collapses, obviously it's not going to be able to expand, and we're not going to see any chest excursion. Pneumothoraxes are serious medical conditions. Patients will obviously have some type of breathing discomfort, but it may not be as pronounced as you would expect. All right, especially a person who has a really good aerobic capacity. You know, they'll be in some pain, they'll be definitely in some breathing discomfort, but you may just think that they're just having, you don't think anything of it. So you really got to focus on this because that's really what we're assessing for. Now, if you see very small amount of chest excursion, then what Carlos was saying, ankylosing spondylitis, I would definitely be concerned of. All right, then there's a couple of tests that we would do. Let's throw in some ortho stuff here. What are some tests that you guys know to test for ankylosing spondylitis?
Chest expansion.
Chest expansion test is one of them.
I think that was the only one.
Yeah.
You guys ever learn about Amos sign? All right, so I won't get into that just yet. Okay. All right, so again, we have the top, we have the middle, and then we got the bottom part of the lung fields. Okay, and 1 or 2 breaths each is fine. One is fine if you feel that you've gotten a good enough read on the chest excursion. That's perfectly fine. Now you saw where my hands were. All right, my hands are basically, just kind of relaxed at the top. I do kind of put them here along the outer part of the rib cage, and then on the under part of the rib cage. Okay. So what I'm doing, as you can see, this is perfectly fine. You can have the rest of your hand on top of the gown, so that way you're minimizing the amount of contact that you're making with the patient so that they feel a little bit more comfortable. Fair enough? All right, so that is the palpation excursion component. Now let's go into the palpation fremitus component. So for this, he's going to cross his arms. So go ahead and kind of cross your arms. That's okay. And lean forward. Now, what I'm going to do is I'm just going to use my MCP joints here. I'm going to place my hands along his spine, and I want you to repeat the number 99 for me.
99.
Nice and loud.
99.
Keep going.
99.
I'm going to move. Keep going.
99. 99.
Keep going.
99.
And keep going.
99.
Good. Relax. So, while he does that, I feel vibration in my fingers. That's fremitus. Okay? The vibration should feel evenly on each side. Now, Dr. Sherman, everyone does it a little differently. You saw I did 4 points. All right? I did a point here in the top, middle, bottom, and then I also went a little lateral. I definitely suggest you do that. So basically, you'll practice, and you're going to feel the vibration. All right? If the person's not speaking loud enough, have them speak a little louder. Why do we do this? Well, here's why. If there is fluid in the lungs because of pneumonia or some other type of infection, guess what's going to happen? You're going to feel increased vibration, also known as increased fremitus. So, again, I don't want to give you a scale because I really can't give you a measurable scale, but you'll feel it, right? So you're going to get used to what normal is like, because everybody here should be normal. So really get used to feeling that vibration. If you feel a really pronounced vibration on one side, then you're concerned that there could be something called consolidation. Now you're going to learn in 6th semester when you look at chest radiographs what consolidation is. It's an area of fluid that usually represents pneumonia. All right? Pneumonia is a very, very serious condition. Obviously, I'm sure, you guys know going back into history, people used to die from pneumonia all the time. Now it's definitely, it can be treated, but if left untreated too long, pneumonia can definitely be fatal, especially in your immunocompromised patients, patients that are older or younger. and also patients that have some type of autoimmune issue. Why? Because usually they're on some type of medication that suppresses their immune system. So a lot of things you got to really take into consideration, with physical exam. All right, so increased fremitus, meaning increased vibrations, usually indicates some type of consolidation. Decreased in fremitus, meaning you really don't feel anything. You want to think of emphysema, air trapping disease. All right. Now, how are you going to know the difference between increase and decrease? You're going to practice it for many months, and then eventually many years. You'll start to learn what normal feels like. So most often, people are going to have increased fremitus if you're going to experience something at all. All right. So does anybody have any questions on the palpation component? All right. So we have the excursion and we have the fremitus. You know why we do it. Okay. So let's move on to percussion. Okay. So, percussion. Have you guys percussed with Dr. Chinell yet in orthopedics?
Yeah.
So you know the technique. Everybody, put a finger down. Take your third digit, put it on top of your second digit, and kind of curl your fingers a little bit. Okay? And just kind of start doing this. You see how my wrist is very lax? And really what I'm doing is I'm moving my forearm, and basically the wrist is just acting as a hinge. Why is that important? Because when people percuss, they do this. Rigid wrist. Not really the right way to do it, because you're not going to get a good percussive technique to actually produce a resonant sound. So what I always like to tell people to do is just practice. Now, if you got bigger fingers, you can get away with not doing the reinforced. That's fine. But usually try to percuss with one finger. Because if you start doing two, you may get, like false positives. So really practice that percussion technique. So we're going to do this percussion technique on his back. So go ahead, cross your arms for me and lean forward. You're going to make a Z pattern, and you're going to hit 10 to 14 spots. Keep that number in the back of your head, because they will ask you on Part 4 boards. How many spots would you do this? If they don't ask you, you will do 10 to 14 spots, because that's what they're going to look for. All right? So we make a Z pattern. All right? You can stand, it doesn't matter. You can stand either side. So we start in one spot. And you see I'm making a Z. And you'll do that all the way down the spine. Okay? Is it the most accurate? No. Is it a good skill to do? Yes. Okay? It sure is. All right, so you'll practice the percussion. If you're having a tough time hearing resonance from normal, I don't want you to beat yourself up over it. Like I said, it's definitely, really what we're assessing for is masses. Again, excessive inflammation within the lung tissue. Instead of it sounding like a nice resonant noise, it's going to sound like, hitting a brick wall, meaning you're going to hear nothing. It's going to hear like this dull, dull noise. So that's really what we're trying to assess for here. All right, so that's percussion. Pretty straightforward. Next is auscultation, okay? Now, what we want to go over is breath sounds. Has anybody showed you a website where you can go to actually hear normal breath sounds? I'm going to post it on Canvas through Littman, and they have both normal breath sounds, they have normal and abnormal heart sounds, so you can actually get an idea of what crackles sound like, what rails sound like, what do normal breath sounds sound like, all right? So you can see here, this is right from Bates. These are the definitions of normal breath sounds. You have your tracheal and your bronchial breath sounds, all right? These are the ones that are generally heard when somebody expires. You're going to hear inspiration and expiration. That's one full breath cycle. So when you're assessing somebody for breathing, you have to obviously make sure you listen on that point for full inspiration and full expiration, because different pathologies happen at different times, okay? So your tracheal and bronchial breath sounds are the ones you're going to hear very loud when somebody is expiring, okay? Your bronchovesicular, well, just like it says, it's a combination. And then the vesicular noise is that noise you hear as somebody's inspiring, okay? Why is that important? Well, when you go down to the next block, you see adventitious sounds. Those are also, you could put in quotes, pathological sounds, all right? These are abnormal breath sounds. So the most common one is crackles and rails. You're going to literally hear, as somebody's inspiring, as somebody during inspiration, you're going to hear this kind of crackly noise. What does it usually indicate? Well, not good. Pneumonia, but also in older patients, congestive heart failure. And that's a big one. Is anybody familiar with congestive heart failure? Have you guys studied congestive heart failure? CHF, you know what the telltale sign is? Bilateral pedal edema and inspiratory crackles, meaning that fluid is backing up into the lung tissue, and this is what you're hearing. Very, very, very bad, okay? Patients with CHF can go from the way Alex looks right now to severe respiratory distress, and within minutes can cascade to, obviously, unresponsiveness and full-blown respiratory arrest. I've seen it, all right? I've been on a lot of calls with CHF, so we really want to make sure that we get really, really, really good at our auscultations. I'm going to post that, not going to lie, I'll have to do it after the CC and after the discussion forum, but it'll be up by Thursday, so you guys will have that. Definitely bookmark it and certainly listen to it as much as possible. You really, really, like I said, you know, you really will be able to save a life if you can intervene early in CHF, because, you know, like I said, it's pretty bad. So that's crackles and rails. Most, again, you're going to hear that during inspiration. The next one we have is rhonchi. And rhonchi is usually like a bronchitis. You're going to hear it, you got to figure where your bronchial trees. The bronchi are usually kind of right around this area. So you're going to hear more of a, rhonchi in that area, all right? You're going to have like these large secretions in the bronchi. That's what we call bronchi, okay? Wheezes, all right? Wheezes are heard during usually expiration. You can have inspiratory wheezing. You can also have expiratory wheezing, all right? Inspiratory wheezing usually is asthma, okay? You can hear it with emphysema, and it's going to hear, has anybody ever heard a wheeze? Okay, you can also have expiratory wheezing. All right, either way, wheezing should be addressed, okay? And then pleural friction rubs, usually don't really, these do happen, but if somebody has like pleurisy or pleuritis, sometimes what you'll hear is, it's difficult to describe, which is why I'll post this. But basically, it feels like, like two pieces of paper kind of like rubbing against one of each other, like they're crinkling. It's like a crinkling sound. It is different than, a crackle and a rail, okay? Does anybody have any questions on that so far? Like I said, the big ones I really, really want you to focus on is what normal sounds like and crackles and rails, because that's usually a precursor of CHF. All right, so how do we do it? Now, this is Emily, so I'm not going to put this in my ears. Remember, your stethoscope, they're angled. All right, so you always want the bulbs here to be pointing towards your nose. So here, everybody see that? They're pointing out, they're pointing towards my nose. So this would be wrong. All right, so you want to make sure that this is in my ear. You want to have the diaphragm. So remember, that's how you switch it. You can see how I'm holding the stethoscope. I obviously don't want my fingers, I don't want, my fingers on the skin. I don't want to basically get any false readings. So I like to basically use two fingers to kind of grip the stethoscope, and that's how I do it. So he's going to cross his arms, he's going to sit forward, and same thing. He's going to take normal than regular breaths, so deeper than regular breaths to an open mouth. So I'll give him that instruction. All right, Alex, what I want you to do is you're going to breathe a little deeper than normal, through an open mouth. If you get a little dizzy or you feel like you're hyperventilating, just give me a wave and we'll stop, okay? So that's important. You don't want the patient to hyperventilate on you. All right, so I'm going to go in those same 10 spots. Remember, I need to be able to hear a full inspiration cycle and a full expiration cycle before I move to the next point, okay? And I'll do that, you can relax, and I'll do that in this Z pattern 10 to 14 times. Now, what should I hear? I should hear normal bronchovesicular tracheal breath sounds. What if I don't? What if I hear one of those adventitious sounds? Well, we want to run a couple of tests. So the first thing we want to do is we want to make a note, where did I hear that adventitious breath sound? Was it up here? Was it at the base? Was it in the mid-lung field? Where was it? I'll complete the lung exam. Then what we're going to do is there's a couple of special tests, also known as transmitted voice sounds. Because basically we want to figure out, is this some type of air trapping disease? Is this consolidation? Meaning again, is there pneumonia or some type of inflammation within the lung tissue? So, let's say I was doing our oscillatory exam and I heard a rail over here. And I want to figure out, maybe was it just me or is there something really going on? So there's 3 transmitted breath sound tests that we do, okay? The first one is bronchophony. Now these are all oscillatory tests, meaning that you're going to use your stethoscope to listen. So if this was the abnormal site, I'm only going to do this site and the opposite site, because I have to compare, right? What good is it if we don't compare? So we have to have some normal to compare it to. So let's say I heard an abnormal sound here on the left. I'm going to go to the same level and compare it to the right. So go ahead and cross your arms again. And he's going to bend forward. I'll start at the normal side, say 99.
99.
Keep going.
99.
And I'll listen for it
99.
and relax. And then I'm going to go to the spot I think I heard the abnormal breath sound. Say it again for me.
99.
Keep going.
99.
Keep going.
99.
Okay. So, if the sound was more pronounced, meaning that I heard it what I would appear to be normal on the right, but then when I went over to the left, I heard it really, really, really loud. Well, again, same principle we just discussed with tactile fremitus. There could be some type of consolidation, meaning fluid in the lung tissue, usually pneumonia. But what if the noise was a lot lower? It was a low pitch, it was more dull. Then I'm worried about emphysema or some type of airspace disease. Okay? So that's bronchophony. The next one is egophony. Okay? Egophony, or you can just relax for this, but egophony is he's going to say the letter E. 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 And I'm going to listen on the good side and then on the bad side. If his E sounds like an A, again, worried about consolidation. All right? Some type of fluid in the lung. There is no decrease, right? Follow what I'm saying? Like we had for the bronchophone. So here we're just listening for, does the E sound like an A? That's egophony. The last one is the whispered pectoriliquy. That's a tongue twister, okay? But what he's going to do is he's going to whisper 1, 2, 3, or A, B, C. I usually go by 1, 2, 3, 4. I listen on the good side, then I listen on the bad side. Well, if I can really hear him, oh, thank you. If the 1, 2, 3 is really pronounced on the bad side, again, hopefully you guys are starting to develop a pattern, right? More vibration, more noise, usually indicates some type of consolidation. Does anybody have any questions so far? All right, we're almost done with this part.
So you're going to go back and forth, or you're going to go 1, 2, 3, 4, go to the other side?
Yeah, and I'll do it as many times as I need to figure out my, yeah. And if I have to go...
Like the 10 to 14 spots?
No, just where I heard the abnormalities.
Okay.
Yeah, if you heard them in both, well, then we got a lot bigger issues. You can also go points above and below if you have to, okay? But usually patients that are showing symptoms, they have an abnormal lung exam, Usually we'll send them for chest x-ray and we can evaluate. You'll learn all about chest radiographs in 6th semester. We do get pretty involved with that, so that'll be good. All right, questions so far? Cool beats. All right, so spin around. All right, so that was the posterior lung exam. Now let's go over the anterior lung exam. A couple of things we want to assess for with the anterior lung exam. Again, rate, rhythm, and depth you've probably already done both from an anterior and posterior perspective, so as long as you've done that, you're fine. We want to assess his fingernails. Has anybody ever heard of the term clubbing or seen clubbing, pictures of clubbing, right? Yeah, exactly. They literally they look clubbed. So we want to look for clubbing. We want to look for these splintering hemorrhages in these fingernails, which could indicate some type of pulmonary issue. All right? We could certainly Google these images if you really want to see what a couple of different, clubbing scenarios or splintering hemorrhaging scenarios look like. Obviously, cyanosis is a big giveaway. What is cyanosis? Anybody ever heard of that term? What is it? It's like a bluish, not just of the lips, but really in any part of the body. But definitely the lips are usually the most effective because they're a highly vascularized structure. So if the lips look a little pale to you, certainly under your fingertips, they should have that nice, again, if you're not wearing nail polish, of course, they should have that nice pink complexity. If they're pale, kind of dark, like a bluish tint, again, could indicate poor perfusion or poor oxygenation. So we want to consider, hey, is this a circulation problem? Is this a pulmonary problem? And this is what I was talking to you before, where parts of the cardiac exam and parts of the pulmonary exam, there's going to be some crossover. All right, and this is one of those scenarios. Okay, so that's what we're going to do for him there. Two other things we want to look for. Now, again, I'm just going to keep his gown on for today for this purpose, but we do want to try to examine him without the gown if we can, because what we do want to look for is something called a pigeon chest. Anybody ever seen a pigeon chest? What's that? Yeah, it's like pectus. There's two things. It's called pectus. There's one, pectus excavatum, meaning like it's caved in, and then pectus canariatum, spout out. All right. These are deformities, and we got to further look into them. People have them for a variety of reasons. Do you guys go over and lecture like some of the why somebody has like a caved in chest?
Marfan's.
Marfan, exactly.
Yeah, that's a big one.
Yeah, Marfan's is the biggest one. Okay.
But just because someone has a pectus excavatum or peritoneum doesn't mean they have.
Exactly. If you see it, they've never really been worked up for any type of Marfan's or collagen issue. Not a bad idea to run them through some more tests, and before you start thrusting on their spine, we want to make sure somebody doesn't have a Marfan's, because obviously, that could definitely be a contraindication of manipulation. Okay? All right. So that's our inspection component. Now what we're going to do is we're going to do our palpation component. All right? Palpation is going to be done seated. Everything else from this point on after the anterior exam will be done supine. So, what were the two components to palpation? What'd you guys learn? Palpation. Excursion. And what's that called? Fremitus. Right? Good. So,
I know, sorry.
I'm glad you're practicing dental health. So,
Note that excursion is oftentimes referred to as expansion.
Expansion.
Because there's something you'll learn in 5th semester called diaphragmatic excursion, which is a completely different animal.
Yeah, we actually measure that.
Yeah,
that's
that's
something
actually
that
measured with a tape
I'll show you.
measure.
Yeah. Okay. All right. So, like I said, from this point forward, everything is done supine. So just the inspection component on the anterior exam we do with him seated. So we get him supine, and what we want to do is the same thing. Now, obviously, depending on the sex of the person, hand position may have to change. So we either do 3 points or we do 2 points. If it's a female, we'll go above and below the breast tissue. Again, same principles. We're using his sternum as a midpoint. You want to go parasternal. All right? Remember, the sternum is a little bit wider than the vertebra. So you're going to have to go a little bit wider. get a decent tissue pull, and then go ahead with that lateral to medial tissue pull and assess for excursion. Okay? So his arms could be at his side like this. Palpate where his sternum is. Okay? I'll come here, I'll come here. Go ahead, take a deep breath in for me. And again, what I'm looking for is, do I see my thumbs displaced laterally, and do they come back together medially? Same speed, are they even? Because like we were talking about, we don't want to, we don't want to miss a pneumothorax. That would be bad. Okay. So we got that. Now, in your female patient, go below the breast tissue. Here's rib 7. I'm along the angle of the rib. Tissue pull is key with this, guys. I can't stress that enough, because if you don't do a tissue pull, go ahead, take a deep breath in. You got nada. You got nada. Tissue pull now, go ahead. Oh, I got something. Good. And when you take emergency procedures from your 5th semester, this is part of your trauma scan, okay? About, having to do this. Why do I have 2 stethoscopes? Yeah, I have no idea. Like, really?
Now, besides the expansion of the ribs, are you also looking for the bucket handle movement of the ribs as well?
So the bucket handle movement is going to be more from the posterior. You're assessing for rib motion with that. That's an orthopedic test. All right, we're trying to basically see if there's a rib anomaly, if there's a rib dysfunction for the rib joint. Yeah, that's something that we do posterior. All right. Yeah, here we're just basically, you're using the rib as a structural mark, but really what we're assessing for is, are the lungs basically expanding and contracting evenly? Okay, but that's a really good point. All right, so like I said, female, above and below the breast. If it is a male, obviously you could certainly do the middle point. Fremitus, same thing. Now, where is your apex of the lung? Where is it? That is not the apices.
The top?
Above the collarbone. Okay? I am a stickler for this, and those that have taken an OSCE know, because I have made comments on it. And I know Dr. Lyon has too. Why? Because there's a specific type of a tumor called a Pancoast tumor. Pathology can form in the apex. Pancoast tumors are often missed because nobody finds the early signs of them. And guess what? Like anything, if we don't get to it early enough, it can be fatal. Really easy way. If we start to witness an area, or if I start to notice an area of consolidation in the apex, oh, all right, let me get a chest x-ray. Ooh, that looks a little funky. And that person can start going through the motion, get tested, and then get treated in a much more efficient manner. So the apexes, I cannot stress that enough with the anterior lung exam, you must hit the apex with fremitus, percussion, and auscultation. There's no rhyme or reason about it. You have to do it. Okay? So with the fremitus, again, you see how I kind of angle my hands a little bit, so I don't want to do this, because that just looks kind of weird. So I kind of angle here. I'm on the apex. Same thing. Say 99.
99.
Keep going.
99.
And then I can come here.
99.
Now watch.
99.
Right? So you can go right down the middle. So not to put my hands over this area.
99. 99. 99. 99.
There you go. All right, so that's kind of how you can do it. And that works for both sizes.
Is there a reason why we say 99?
No, you're just trying to cause vibration.
You can also say blue balloons.
Blue moon.
Or blue moon.
Blue moon.
Blue balloons. Balloons.
Yeah. Is there a reason why you're wearing black sneakers today? There you go. Got a little fun, right?
Thank
I
you.
was just wondering
Thank you for doing this.
Oh, yeah, absolutely.
Okay.
Yeah, like I said, because a lot of people, just because females, obviously have, tissue there, we still got to examine it, right? But there is a way to do it appropriately. So, prayer position. Now,
Are they going to have any tenderness with the consolidation?
that's a good question. They may. Usually patients with pneumonia, obviously the biggest one is going to be fever. They're going to be febrile.
What was that?
The Pancoast tumor.
Now, with a Pancoast tumor, is there anything else besides the?
Not early stages.
No.
Yeah, have you ever had one, Brad? Neither have I. Yeah, no, they're nasty though. Because again, And that's honestly with most tumors. You know, a lot of them really start with very minimal symptoms early on, but a lot of people, you know, just miss it. You know, it's like with colon cancer, with dark stools. Nobody really thinks anything of it, but that's usually like a huge red flag. So, okay. All right, so that's Prematus. Okay? Percussion, you guys learned it, right? Really practice that technique I showed you. And if you want, the patient can turn their head to either side, you know, when I'm doing the apex. So watch, if I'm doing the right apex, you know, I don't want it to like, you know, look like I'm gonna hit him in the head. So he turns his head to the left. Now again, this should be skin on skin. Good. Walk around, turn your head over to this side, and I get the other apex. Like I said, I don't care if everything else is sloppy, you gotta do the apex. All right, then he puts his head back to neutral, and then same thing, just do your Z pattern. And again, if it's a female, you'll just basically omit that section and go above and below. Okay?
You're just tapping your hand there just to not tap him, right? Usually.
Yeah, you mean like this? Yeah. Yeah, that's just, you know what I mean. I can't do air percussion. That'd be pretty awesome.
What would it sound like if you did have
Dull. Not going to be resonance because there's going to be some type of fluid. There's going to be some type of excessive tissue in there. So it's going to sound, instead of that, you know, nice thump, thump, it's going to be like, ah, it's going to sound like this. Yeah, that's a good one. Okay? Lastly is auscultation. Same thing. You're going to use that Z pattern. All right, and obviously these would be in my ears. Again, hit the apices first, turn his head to the right. Find my apex. He takes that deep breath in, he exhales. And again, the same principle. This I kind of do prompt them because I really just want to hear it. Go ahead and turn to the other side, same thing, and exhale. And then after, I'll give him the instruction. Okay, with an open mouth, just take a little bit deeper breath than you normally would. If you start to feel a little bit dizzy or you feel like you're hyperventilating, just give me a wave and we'll stop, okay? And then you'll do your Z pattern, 10 to 14 points. Again, making sure that on each point, you listen for the full inspiration and the full expiration cycle. Okay, questions? You guys think you can practice this? Oops.